Thank you, Beth. Thank you, Tanet, for having me here. Just a quick note, I think that just being here is way harder than doing a CTO, I think. But anyway, thank you anyway. Before I start talking about the CTOs, I just want to, I would like to talk about the evolution of intervention cardiology in the last 20 years. Like Dr. Sharma said, it's been a lot of changes for the better in terms of better equipment and catheters. From imaging modalities, we had IVUS 20 years ago. We didn't have OCT. Now we have OCT, FFR, NIRS, infrared chemograms. We moved to left ventricular assist devices like we had 20 years ago. We only had balloon pumps. Now we have impellas, and we have tandem hearts, cardio help, more powerful but less invasive. We also have to talk about the left main, unprotected left main. The way we treated before, the patient had a left main. We found a left main disease. Patient 99% of the time went for bypass. Now patients have other options. So let's start. Okay. So before anything, we have to define what is a chronic total occlusion, or CTO. By definition, chronic total occlusion is it's an occlusion that's been there for more than 3 months with a TIMI zero flow. The TIMI flow classification it divides into 4 stages. The TIMI zero flow, meaning no perfusion. TIMI 1 flow, you see a penetration without perfusion. TIMI 2 flow, partial perfusion, and TIMI 3 flow, it's a complete complete perfusion. So when you treat a CTO, the critical measure, it's 20 millimeters. Why? Because less than 20 millimeters, the success rates they're way more higher. More than 20 millimeters, the success decreases substantially, and which you have to consider the retrograde technique and dissection and reentry. So what is the morphology of these so-called chronic total occlusions? It's full of debris, meaning we find necrotic areas, hard plaques, calcified areas. So this is a basic angiogram of a total occlusion. You see the LAD here. You see the proximal LAD. And the mid LAD is completely gone. By definition, you see the first septal here, so it's actually the mid LAD that is completely gone. You see the collaterals here coming from the CERC LPL, and you can see the proximal cap as well as the distal cap. So what are the benefits of fixing these so-called CTOs? And the benefits are very substantial. The benefits are you relieve angina, you improve exercise tolerance, improve survival, better LB function, you reduce the need of a bypass, reduce ischemic burdens, and also you reduce arrhythmias. So what are the patient considerations for nurses and techs, especially for nurses? For example, the patient sedation is the key. These cases are usually long, and it can take from anywhere from an hour to 5 hours. So the patients have to be well sedated. You have to have reversal agents. Here in China, we use Angiomax. I know there's other institutions use heparin, so you have to have your reversal agents on hand. You have to check ACTs constantly. You have to, for the techs, you have to be aware of the radiation as well as the contrast. Also complications. Once when you deal with this type of occlusions, you can always have perforations, tamponade, and also problems with the groin. So what makes a CTO, what are the favorable characteristics? Short segment, less than 20 millimeters, like I said before, the tapered tip, no side branches or bridging collaterals, straight segments, usually LADs, RCAs are considered are easy CTOs, and functional CTOs, faint channel, you can visualize the segment. Unfavorable characteristics, calcifications, long segments, more than 20 millimeters, blunt stump, flush ostial CTO, bridging collaterals, side branches, and the hardest CTOs are the circumflex because of the angulation. So the axis, you have to assess collaterals first. If no collaterals are seen from the contralateral vessel, you go with a single axis. And if you see collaterals from the other side, then you have to get the dual axis. You could be the femoral or two femorals, or one femoral, one radial. The approach here, I don't know if you guys heard about the hybrid algorithm. This is what we use here. Our first attempt is antegrade. The second, it's again antegrade, and our third attempt is usually retrograde. The guy selection is one of the keys for a successful PCI. Why? Because you need to have a lot of support for these catheters. The catheters have to sit coaxial to the vessel, and without that, you probably won't be able to deliver all these wires and devices. Here in China, we, for the most part, when we use a left main, we use FL guides. And when it's LED ostial with a long left main, we use the VL guides, VL35s. For LED ostial with a short left main, we use FCLs. LED proximal segment CTO, it's the VL guides are the most commonly used. For the RCA, we start with the most common guide are the Lima guides with side holes. You have to have side holes in this type of cases. Why? Because if you don't have side holes, you're going to have a damp pressure, and it's going to be you won't be able. It's going to be an occlusive pressure, and you won't be able to monitor the waveforms. Okay. The wire choices are when you first start a CTO, we usually start with a regular filter, and after the 20-30 seconds, we usually can tell how the CTO is behaving, and then that's when you start escalating the wires into more stiffer wires. You start with a Miracle 3. Miracle 6, you go into Confianza, more stiffer wire, more aggressive wires. The higher the number, the stiffer the wires. And how they measure the stiffness of the wire is, for example, a Confianza Pro 12. It takes 12 grams of pressure to bend the tip. And that's how the stiffness of the wire is it's measured. So we go from 1 gram, like I believe a BMW is 1 gram, to a Stato 40, which is 40 grams of pressure to bend the tip. Again, this is we go back to the evolution, not just in CTOs, but in the whole intervention cardiology field. And you see from 2000 to 2010, as you move along, the success rate keeps going higher, and the complications keep going lower. Why? Because of the newer equipment, better wires, better catheters, also better trained nurses and techs, I think. When you deal with this type of occlusions, you always have to be aware of and be mindful of the complications that these procedures can bring. Some of them are the biggest one is a perforation. There's three main types: the main vessel perforation, the distal wire, and the collateral perforations. Again, the complications, it can be coronary occlusion. You have to, when you're dealing with this type of procedures, you need to have jaw stents, covered stents in the nearby. You have to also have coils. Here in the lab, we have a checklist when we every morning we check for this type of equipment, because without this equipment, I mean, I wouldn't recommend to even attempt to do this type of cases. Again, for nurses and techs, the people who are setting up these tables, you need to have. For CTO PCI, the introducers are longer compared to a non-CTO PCI. You start from a 25 cm to all the way to 45 and even 60 centimeters sheath, because you need to have more support, especially if there's a tortuosity in the groin or the catheters. Also, especially when you do the retrograde, they have to be smaller. Standard catheters, as you know, they're 100 centimeters, so you need like an 85 or even a 90 centimeter catheters. The coronary angiography is got to be bilateral, especially if you're doing a dual access. The wires, you need a specialty wires, stiffer wires, and the wire support. You need the micro catheters like Fine Cross, Turnpike, Micro 14, and so on. The tools that like I was saying before, the tools of management, the tools for complication management, you need to have coils, you need to have cover stands and paracentesis equipment in the room. So we have a case of 59-year-old male with a history of all of these risk factors, high cholesterol, diabetes, COPD, ischemic cardiomyopathy, suggesting a low EF. And came to the cath lab with a positive stress test with inferior ischemia, meaning that this myocardium is viable, and it's appropriate to go in and go ahead and open this RCA. I can go back later. So we take this picture again. This case was referred to us, but with to Dr. Keeney from another institution, where the first attempt and was failed, and she was going to try to go and retrograde. You can clearly see this is the proximal middle RCA, RV branch, and distal RCA is completely gone. Right here. You take there's a dual axis. You can see this beautiful collaterals from the LAD and feeding all the distal RCA. So the retrograde approach, first you got to select the collaterals. There's two types, epicardial and septals. You have the dual axis here, double injection of the left system, coronary system, and you can clearly see good septals going into the RCA. So what are the steps? The first is, like I said before, you have to septal the collaterals. You have to enter the septal with a filter FC. FC stands for fine control. I always thought it was it meant for collaterals, but it means fine control. The second wire of choice is a whisper with a Corsair Catheter 150 cm. There's two sizes, 135 and 150. You need to use the 150 for this type of case. You can see the Corsair Catheter here with a tip. It's like a screw type tip. You can see now the Corsair with a filter. The step number 2 is you got to cross the distal cap. You got to transverse the length and cross the proximal cap. And this is when you escalate wires as needed. And you can go from like I said, from Miracle 3, 6 to more stiffer wires like Confianza, Gaia 1, 2, 3, Progress, Pilots. Here they cross, and the third step will be externalizing the wire, which means advance the wire into the antegrade guide. You have a trapping balloon here, 2512, so the wire still it doesn't move. Then you have to advance the Corsair into the antegrade guide. That's when you got to exchange to a 335 cm Viper wire. And by doing that, you're creating a conduit between the left system and the right system. The step number 4 is it's called the microcatheter technique, which you have the Corsair on the right and the fine cross. You go antegrade, and they both meet here. At this point, you remove the Viper wire, and you remove the Corsair, and you perform the retrograde Vesselangiogram just to evaluate any dissection or thrombus, and then you remove the retrograde guide. Step number 6 is open the CTO. You get up to 300 Grand Slam, advance into the distal vessel, remove the fine cross, and you open the CTO. This is the final angiogram. This is a long stent, 38 stent, and this is the final picture. So in summary, chronic total occlusions are difficult. However, complete revascularization can help patients clinically and symptomatically. Techniques and equipment continue to evolve with this better catheters, better equipment, better trained nurses and techs. This case, the success rate increases significantly, and the step-step approach helps simplify these complex cases. Thank you. I had to have a selfie. Thank you.